Hello, everyone. I want to welcome you all to the 2024 edition of Pocket Talks. This is a series of talks that are designed for community providers that see patients, diagnose and treat patients with dementia and neurodegenerative diseases. This is an overview of the lecture series for this year. We'll be starting off with today's talk, which will be distinguishing normal from abnormal aging. And then we'll go through the series throughout the rest of the year. We'll be uploading these to VuMedi, which is a new adventure for us. So we're welcome to be joining with them and having a new audience for these types of talks. But with that, I will go ahead and jump in. We try to pack in about 20 to 30 minutes of information with some time for Q&A for the live sessions. If you want to join in live sessions, that would be even more beneficial for live Q&A. So with the objectives of this talk, we want to focus on what is that normal aging process versus abnormal aging, but we'll be focusing mostly on cognition, right? You could talk about a lot of different things with aging. We'll be focusing on cognition and when should we be asking about changes in cognition, when to be concerned, how should you be asking those questions, and who should you be asking? And then if you are noticing potential cognitive concerns, should we be referring for further testing? I'm going to introduce a term throughout the talk called subjective cognitive impairment. So we'll define that later. And then we'll talk about a few research opportunities as well, although that'll be for rotating slides, usually in the Q&A section. And to note, right, next week we'll be talking about mild cognitive impairment. This is really a bridge, right, to recognizing that versus normal aging, and then we'll be focusing more on the diagnosis and workup in the next Pocket Talk. So when we look at like what primary care physicians feel is most challenging about diagnosing mild cognitive impairment, here is what the breakdown looks like. This is a great figure from the Alzheimer's Facts and Figures Special Report on mild cognitive impairment. And as you can see, most individuals, and rightly so, struggle with differentiating that line between normal aging and mild cognitive impairment. And I will tell you up front, part of that is just due to poor tools being used, right? And so that's going to be part of what we emphasize in this talk and next talk is utilizing better tools to allow us to do this a little bit better. Obviously, this person must have hit the wrong button, right? I don't think anyone would reasonably choose this option, or if they did, this talk is not for them, right? So when we talk about normal aging, right, there's a lot of things we could graph on here as far as function and age, muscle mass, bone density, brain volume, memory capacity, right, processing speed. There's a natural decline here no matter what we do, but we all want to be more of this green line rather than the yellow line and the red line. And, you know, there are lots of things that we'll talk about in the series of how do you try to maximize, you know, reducing your dementia risk over a lifetime. What we're talking about is the cognitive aspect. So in that normal aging box, having troubles thinking of someone's name is universal, right? You know, I like the quote from one of my mentors that described it as we get older, we have a larger library, right? And it takes us longer to find that book or name that we're looking for. So it's not like you forgot who this individual was, but it is it comes to you later when it's less convenient. Misplacing items around the house. Many people do this. Walking into rooms and forgetting why you walked in there. Many people do this as well. My children do this, right? I do this. Obviously, as we get older, our radar goes up. We have family history, and we see our friends getting diagnosed, right? As we get older, you know, our radar is going to go up for these things, but these technically fall under that normal aging box. The things that we see with multitasking, so with changes in the brain, sometimes these are more difficult. Occasionally, patients will forget appointments, maybe some medications here and there, or a task, but then remember it later. Oh, shoot, I forgot to do that, right? It's not like they completely lost track of it. We also see some changes with sustained attention, which probably overlaps with this multitasking component. Now, when we look at like cognitive test scores over time, if you have age on the x-axis and then these z-scores is like how close are people to the mean or the bell curve, right? The 50th percentile across those age groups. Well, most of these scores you can see go down with time, right? And we start to reach a threshold around age 50 to 55 where we're actually going into negative z-scores, but these are still within normal limits for their age. But look at the speed of processing, working memory, long-term memory, all these scores are decreasing with time. The only exception to this is world knowledge. So this is like vocabulary, semantic knowledge, both vocabulary and non-vocabulary semantic knowledge. So oftentimes that's the one thing that will stay steady or potentially even increase with time. And so when we do these memory recall tests, right, we have a different set of norms for different age groups, right? And we just have to factor that in when we're trying to decide, well, is this a normal aging individual or not? We know the brain changes with age. If we scan someone's brain at age 50, 60, 70, 80, 90, 100, right? There's a natural shrinkage of the brain. It doesn't get bigger with age, unfortunately. What I'm highlighting here is the hippocampal structures, which we can also call the medial temporal atrophy scales. That's what this MTA stands for. So if we do a coronal slice of the brain, which is showing you here, and we're looking specifically deeper into these hippocampus structures, these are the structures that are important for episodic memory, so storing new memories, for long-term memories, and also for just short-term memory recall. Now, when we look at this box, so the one I highlighted in the top right, this is normal aging, right? We expect people 65 and older to have some shrinkage of those memory structures. However, MTA2 is usually when we start to see folks come into the clinic with mild cognitive impairment or early changes in objective memory scores. We'll define that later in more detail. And then an MTA3 is typically more of a mild dementia with moderate and severe along the bottom here, obviously taking some age into account when we're in this gray zone here at MTA equals 2. What about abnormal aging? So what are the types of things that we'll typically hear patients and more likely the patient's spouse or family members describe? It's a change with everyday tasks and having difficulty with doing things like tracking the monthly bills, following a recipe, right? Finishing tasks. Electronics are a little bit tricky, especially if someone was not that familiar with various electronics and they can't figure it out when they get a new one. But if it's like, well, we really haven't changed anything and now they're struggling to use the computer, that is a definite red flag with when they were able to do it previously. And we're also looking a little bit more for consistency with things, right? Not just like a one-time scenario, but these are things that are starting to happen more consistently. That is more meaningful that for that abnormal aging bracket. So that goes along with telling the same story, repeating questions, troubles having, word finding difficulties, abruptly stopping mid-thought where patients can't really continue the thought. They might lose their train of thought. A classic one we'll see when the patient is with the caregiver, with the physicians, they might just keep looking to the spouse for answering questions. And then the consistency is a key here. What are other things we see? So getting lost is, those navigational place cells are basically within those hippocampal structures in the medial temporal lobe I just showed you. They're right adjacent to them. And so we'll often see difficulties with navigation when we are seeing clear objective memory changes. Personality changes may actually precede cognitive changes in some individuals. So there is this term that we're trying to think of in literature called mild behavioral impairment, where often we'll see a withdrawing of activities, especially with more complicated hobbies and social activities. There's obviously psychiatric overlap with a lot of symptoms, and diagnosing and treating these things are important. And if things improve and don't get worse over time, then that argues against a neurodegenerative disease. But These need to be addressed up front when they occur. Orientation changes, so that's losing track of kind of time and place. So that's a common one. And then judgment problems. So our patients are at high risk, vulnerability to scams, poor financial decisions. So when should I be asking my patients? This is a slightly controversial topic, but most would suggest a reasonable age to start asking is when we are reaching that Medicare annual wellness visit, so around age 65. I plot, basically once we reach 65, we're getting closer to double digits for prevalence of mild cognitive impairment in older adults. And you can basically double these numbers because they look very similar numbers for dementia and these brackets as well. So meaning 65 to 69, almost 10% of individuals have dementia, but that number increases with age as well. On a mini cog, that's something that can be done without an informant. You can just do that quickly in the clinic. That's a reasonable test for individuals with pressed time. So knowing that time is a major issue, especially when patients have a long problem list with these annual wellness visits. One that I actually prefer, and I think one that makes even more sense than the mini cog, and you can incorporate this in a number of ways in your clinic, is sending out an 88 form, which is an 8-question yes or no form. I'll show you that here and also in the next talk. And then if there are concerns raised from this, right, especially from a spouse or loved one, yeah, I'm concerned about these certain changes, then that's when you would trigger to perform a cognitive screening evaluation, but with a good cognitive screening tool. And in some patients, we actually do need neuropsychologic testing. And that's actually the gold standard of how we make the diagnosis of mild cognitive impairment versus normal aging. So how should I be asking? Every single patient comes into my clinic, which is dubbed the memory clinic, right? A complaint about their memory. Hint, it's not always about memory, right? I like to ask them to give me examples. A lot of times patients will not be able to give you clear, concise examples. Sometimes they can, most of the time they can't, especially when we're dealing with short-term episodic memory loss. They are not going to remember those examples. So there are other types of questions you need to be thinking about, though, right? If you ask the same 4 questions to every single patient that comes in with a memory concern, you're going to miss a lot of different types of dementia that we're going to talk about throughout the rest of the series. You're going to miss language disorders and visual disorders. And so, there's different questions that you can be asking depending on the clinical suspicion and depending on their description of some of these examples. So who should we be asking? Should we be asking the patient? You always want the patient's perspective, right? You don't treat the individual that is not the patient, right? So we're treating the patient, but I will tell you with a lot of experience that the subjective history from the patient is going to overemphasize those normal aging symptoms. 100% of patients tell me they have difficulties with names, right? What you're going to miss the true and the more concerning memory problems, the missed medications that are happening, the missed appointments, those things, right? So you need to ask someone else for those types of details. That usually is a spouse or another family member or close friend. Caveats being, right, your history is as good as the informant in a lot of these scenarios, right? But doing the best we can. I'll use language of, sometimes when we're having early memory problems, we might not remember them, right? So is it okay if I ask your husband, can he fill out this 88 form for us? And so what does that look like? This is an example of the 88 form. This was designed at Wash U in St. Louis, a very prominent ADRC in their own right. And this is an excellent tool. So basically it asks the types of questions, but from the perspective of the informant. So that's the benefit here. You could mail this, right? They could mail it back. You can have your nurse do it over the phone. You could do it over the phone. They can fill it out in person. There's lots of different ways that you could incorporate this into your clinic, at least as a good initial screening tool. And if people are checking yes on 2 or more of these boxes, then that should provoke you to proceed with cognitive testing. So, you may get a score of 3, right? And those individuals we would say, okay, that's greater than the 2 score here, so we should do further testing. And in some cases, you might not have a good informant. The mini cog is a reasonable, very quick test to screen. But if these are normal and your suspicion is still quite high, maybe a strong family history, a lot of concern from the patient, right? You may proceed with bedside screening tools in either scenario. However, I would not recommend screening with the mini mental status exam. This is the MMSE. It is not designed to detect MCI. It was designed in the 1970s, way before mild cognitive impairment was ever a thing. We want to utilize better tools. So the Montreal Cognitive Assessment, or MoCA. The STMS is the short test of mental status that we use, and we'll talk about these in more detail in the next talk. In many cases, you may need neuropsychologic testing when things are borderline or when you're not fully convinced that these screening tools are telling the full story. And that's especially true in patients with high education backgrounds and high cognitive reserve. So what does neuropsychologic testing provide us? Well, we literally utilize a normative database where we factor in age, education, and a couple different variables to try to come up with a percentile ranking of how this individual in front of us is scoring compared to their peers, right? We're able to assess this in multiple different brain domains, giving us the most in-depth information about someone's cognitive function. And it really helps establish a baseline. Even if you get everything back normal, this is a good objective baseline for folks that are at high risk later in the next coming years. I can't tell you how many times I've seen patients where I'm like, nope, you're doing well, you're scoring in this range, and you're in the 40th percentile for your verbal fluency, and then you hear, well, I'm an English level, college professor, or sorry, a college level English professor. So this is not normal for me, right? And that happens all the time, but I don't have another data point to compare to in most scenarios. So this term of subjective cognitive impairment, what does that mean? It basically refers to the patient noticing changes. So the patient might be noticing changes in their cognitive function, their processing speed, their memory, but they're able to compensate pretty well, right, for a number of years, 5, 10 years sometimes, where any notice of any subtle decline in cognitive performance on, say, an objective test, we would only know that if we had 2 data points. Let's say they scored in the 80th percentile in their memory scores at time point A, and then we see that they're in the 50th percentile at time point B, and let's say they're in the 20th percentile at time point C. All those are normal scores, right? So we would group them into the normal, aging box there, but we're seeing a clear decline over time that they're able to at least compensate for enough to get a normal score. But basically there's a threshold that usually gets reached to where we say, okay, now you're below the 5th percentile, which is what we define sort of as the abnormal, clearly abnormal score, where we might call someone more of a mild cognitive impairment. And so it's it's actually probably going to be an important thing that we're going to track. This is more of research level information, or at least information that if we have more data points of neuropsych testing over time, we can be more sure of. But when folks have studied this, patients that have higher subjective cognitive score concerns, they are more likely to be amyloid positive. They're more likely to start to see mild behavioral impairment. And these are some of the earliest changes we're probably detecting before we would call something clearly, an Alzheimer's disease etiology. Here's just a quick table that I'll be having in the next talk too, but it helps highlight this idea of how do we sort of group these individuals based on different factors. And so you can see with normal aging, really there's no concerns, at least beyond the normal aging stuff we discussed earlier. The subjective cognitive impairment folks, they may have a lot more memory concerns than the normal aging folks, but they still test normally on our objective testing, right? Whereas mild cognitive impairment, that's where we start to see impairment, clear cognitive impairment, but not interfering with daily activities. So normal here, whereas dementia is red across the board. When we think about Alzheimer's disease across an extended timeline, what we're often seeing is biomarker changes on the research side years before symptoms. And so this has been replicated in multiple longitudinal studies now, even out of China and the United States and in Europe, where we see biomarker changes in amyloid 10 to even 20 years before we see clear cognitive changes on testing, what we would call mild cognitive impairment. So there's this whole window of neuronal injury and biomarker changes that we're just not able to capture at this time with our current tools. We have the ability to do certain tests, including amyloid PET scans, that can detect this rise in amyloid plaques in the brain well before symptoms. And we do have a trial that is enrolling folks in clearing out those plaques to see if we're able to decrease that over time. We're one of the top enrolling sites across the world. It's a worldwide study, and this is trying to target those plaques. So most of these patients have more of what we call subjective cognitive impairment, but in order to make it in the study, you have to be testing normally on cognitive tests. I do have to have one quick word on cognitive resilience. So, patients can have Alzheimer's disease pathology, amyloid and tau, usually at lower thresholds, but even at even larger thresholds in the brain, but still be testing normally, right? I just showed you the graph that explains that. So this idea of this sort of preclinical stage or at-risk stage, meaning you're not guaranteed to get Alzheimer's disease, but you're certainly at risk as more of these biomarkers add up and as they accumulate. But not everyone will progress to Alzheimer's dementia. Part of this is probably genetics, probably environment as far as lifestyle factors. But there's a lot of things that go into this that make it a little more complicated than just saying someone is amyloid tau positive, therefore they have Alzheimer's disease or they're going to get Alzheimer's dementia. That's not the case, right? So we know that these lifestyle factors matter. We know that baseline education is one of the earliest interventions at a population level for delaying the onset of dementia. We know that improved cardiorespiratory fitness results in improved vascular brain health and ultimately decreased rates of dementia, or at least delaying the onset. And we know that a number of other lifestyle factors, especially when added together, start to decrease one's risk of dementia, at least at an earlier time point. And so these things are important, right? And we'll be circling back to a lot of these things in one of the prevention talks later on. So I'm going to end here with an algorithm, right? So everybody loves algorithms. And this is one that, if a patient comes in, they're recognizing changes from their cognitive baseline, right? Or they don't recognize anything, but you're noticing an abnormal mini-cog test on your screening, right? Those individuals are in one camp. And then in the other camp, you might have, where at least you have a positive 88, right? So either of these two scenarios, you're going to want to screen to see, do they have impairment on formal testing, right? And so here is where you might incorporate the screening tools like the MoCA or the STMS, or more formal neuropsych testing. And so there's kind of two pathways to here, right? Now, if they don't have any abnormalities on that testing, then it's more appropriate to call this subjective cognitive impairment, especially if they're the ones that are recognizing the concerns, right? This is likely normal aging in most patients you're going to see. Offering reassurance at this point is reasonable. However, right, if you got someone with 3 family members with a history of Alzheimer's on mom's side, they're super concerned. Mom got it around my age, right? You would probably want to consider longitudinal follow-up, maybe over the next 2 years, just to make sure we're not seeing significant changes on those cognitive tests. Let's say we do get impairment on these tests, right? Then we're really asking the question, does this individual have functional impairment or not? Because if the answer is no to that, then we're talking about mild cognitive impairment, right? If the answer is yes, they do have daily functional impairment, then we're talking about more of dementia, which will be in a future talk. But this is a segue into our next talk, which will be focusing more on that mild cognitive impairment, our definition of it, the different causes, and why finding those causes is actually just as important, or actually probably more important than diagnosing it. So I will go ahead and end there. Thank you all for your attention, and welcome again to the 2024 version of these talks. We're excited to have you all join us.